right, good morning, everybody. Happy Valentine's Day. I'm Dante, and this is my presentation on trauma in pregnancy. So let's say you get a call or don't get a call, because sometimes that happens, and it's a trauma. Just in general, I'm just talking about like kind of like an algorithm as far as how you go about trauma in general, not really anything specific. And the patient's pregnant, right? Either they're 23 weeks, like they say they're 23 weeks pregnant, they're visibly pregnant. I think if you get it from history, I mean, obviously you will want to do ultrasound at some point, but if you don't know if they're pregnant, make sure you look and make sure that they're pregnant, because you don't want to make that mistake and think someone's pregnant and they're actually not. But it's 23 weeks is really important because this is a point where one, you could have a viable fetus possibly. And at that point, I think at like 12 weeks is when the uterus starts to move up into the abdomen and is no longer in the pelvis, so it'll be more susceptible to abdominal injuries. So you got a pregnant person come in, they suffer whatever type of trauma. First thing you want to do is your primary survey. All right. I think this is really important to remember that you can anchor on your primary survey. So if you're freaking out or if you're nervous, which we never do, you can always manage your ABCs, make sure they're intact. And that's kind of the same with every trauma, including this one. Few things to think about during the resuscitation is one, especially if they're hypotensive, lateral displacement of the uterus is a really good thing to do. That's going to prevent compression of the IVC, get more venous return, and hopefully bring up their blood pressure. We used to do lateral tilt, which is no longer recommended. So you just want to do lateral displacement of the uterus, which actually I think we're going to talk about a bit later. Also, another thing you want to think about is the blood that you give during MTP if that's needed. Right, you want to give O-negative blood just to maintain that RH status. I mean, this is a pregnant person, so RH status really matters more than anyone else. Like I said before, fetal monitoring. I don't know if we have the non-stress tests in CCT, but doing an ultrasound, seeing if there's a heartbeat, that's going to be good not only for us, but also for the parent. Make sure to show them, hey, baby's okay. Obviously, if there isn't a more stable situation where they're actually able to see and say like, okay, the baby's okay, that'll actually help them feel better. Because a lot of times, if you're not freaking out, the parent obviously is. Also, if you're doing X-rays, make sure you shield for radiation if possible. One thing to consider is throughout all of this, we're taking care of the parent primarily and not necessarily the baby. So if you need a pelvis X-ray, do the pelvis X-ray. Obviously, that's what's the most important thing, is to take care of them. So from then, we kind of go on two different pathways, which is kind of like how it is for most trauma patients. Either they're stable or unstable. Now, what stable looks like may be a little bit different from what a stable patient may look like in other age groups or other demographics. They can be a little bit tachycardic. That's more so okay. Pregnant people are allowed to be a bit more tachycardic. But we're looking at whether or not ABCs are intact, right? Also, we're looking at hemodynamic instability. If their vital signs are abnormal, they're more so on the line of being unstable versus stable. And so when it comes to being stable, I think using radiographs as needed is really important because, again, we're taking care of the parent. So if someone needs CTs, get those CTs, that whatever they need in order to tend to their injuries and also to take care of them primarily, and have that conversation with the parent and say, hey, we need such and such X-ray, we need such and such CT. It poses a risk to the child, but this is kind of what we have to do in these situations. Make sure they're monitored and all the injuries, like how we usually do. Give ROGAM if there's been a lot of bleeding. Lastly, what's really important for us to remember in these situations is intimate partner violence screening. A lot of the time when it comes to trauma, especially in women of childbearing age, especially of people who are pregnant, is related to intimate partner violence. So in all these cases, I would probably have social work come and talk to them. You talk to them yourself to make sure that when they do go home, they go home to a safe environment. And lastly, you want to have OB see them. Um, Obviously in a this would be a console, not in a code situation, assuming this is like a stable, more so straightforward trauma. Now, on the other hand, when they get to be unstable, if you didn't already call a level 1, call a code 54, call a NICU team, this is kind of when you should start doing that, when you realize that they're unstable, because this can go downhill really bad, really quickly, and a lot of times these people end up needing surgery. And specifically, and we have cases like fetal bradycardia. If you look on the ultrasound and notice that the fetal heart rate is low. Persistent decel, that we have a non-stress test, we realize they have persistent decelerations for those who are still able to interpret those things. A large abruption, right? They're bleeding a lot. Uterine rupture, you feel like someone's bleeding out. This is a situation where you want your surgical teams, because they probably want to go to the OR. This is in addition to anything trauma related separate from the pregnancy. And what we can do a lot of time for making sure, aside from making sure they go to the OR, give mass transfusion as needed. But for the most part, a lot of these people just need surgery, and that's kind of the reality of it. So making sure you get those surgical teams on board as early as possible and as early as needed is really important. Now, of course, this is in the context of there being the parent being, having a pulse, right? So on the other end, we're going to talk about perimortem C-sections later, but if mom goes into cardiac arrest, I think the next thing you do is, perimortem C-section, right? One thing to really stress about this is in a traumatic arrest, we're not doing chest compressions, we're not doing ACLS. So you don't have to wait that 4 minutes or those 2 rounds of CPR before you do a perimortem C-section. This is something you should potentially do right away. And this is something we should actually really be prepared to do, as daunting as it may seem. And it's good we're going to practice on it later, because the reality of it is if we have someone who's pregnant, they go into cardiac arrest, one thing that can achieve ROSC is them no longer being pregnant. And this is in the traumatic arrest and also in non-traumatic arrest, which is why we do it, again, to salvage the fetus, but also in order to take care of the parent. Say you do a perimortem C-section, you called your code 54, and for some reason, nobody's still there. You're still there by yourself. One thing you can do, give oxytocin. So that'll help tampen out bleeding. We're also going to talk about this more, so I'm not going to go too deep into it. Try to massage the uterus, remove products on conception, like deliver the placenta. You can try packing, try to do whatever you can to stop the bleeding, because obviously you cut someone open, us as non-surgeons wouldn't know how to do that in a very clean manner. And also, we're not going to be super good at closing up and preventing the bleeding. We're just trying to save whatever we can do in this situation. So that's kind of the rundown of a basic rundown what we would do as far as if a pregnant person comes in and has some type of trauma. Couple takeaways. The well-being of the parent is the primary focus. You're going to be pressured by, if not the person who's pregnant, by other people to do what they can to save the baby. That's not our primary focus, right? Because if we can't save the mother, we can't save anyone who's pregnant, then we can't save a baby, right? Another thing that's really important to remember: the primary survey does not change in any situation. You anchor on your ABCs, you can never really go wrong. That's one thing I think you want to remember. That there are obviously other parts to it that I talked about earlier, but if you want to remember that, that's a great way to make sure you are being appropriate in your management. And lastly, perimortem C-section indications. Again, in a traumatic arrest, we're not doing chest compressions. This isn't a time for us to do ACLS. Obviously, use your judgment. Just because someone got into a car accident and they had cardiac arrest doesn't necessarily mean it's a traumatic arrest in a way that we may see it, and chest compressions may actually be appropriate. But in a situation where they're not appropriate, we aren't doing the ACLS. We're not doing the standard code practices as we do otherwise in a non-traumatic arrest. And yeah, that's it.